So I'm going to kind of take it back a little bit more basic and talk about first trimester vaginal bleeding. So, oh goody, I was hoping she would talk about that. Why do we not talk about this? It's rarely life-threatening. We see it all the time. Most of us take these patients completely for granted, but your interaction with these patients will likely be one of the more impressive interactions they've had through the course of their pregnancy. You rarely go home to your significant other, to your parents, and say, I saw 5 cases of vaginal bleeding in pregnancy today. But again, these are very important interactions that you're going to have as an EM doc. So what's the case, right? This is pretty typical. You have a 32-year-old G1P0 female, dark brown vaginal bleeding for 2 hours. She found out she was pregnant last week. She made her first OB appointment, and she hasn't gone yet. And then she started bleeding, so she called the OB, and they said, come to the ER. So now you're actually the first interaction she's had with the provider for this pregnancy. So what's the workup? We all know this, right? You go, you say hi to the patient, you draw a rainbow of tubes. Every physician may have a different cocktail that they do, whether or not, everyone does a CBC, a beta. You might or might not do a chemistry, and depending on where you work and who you work with and how early the pregnancy is, you may or may not want to do a progesterone level. There is evidence that early bleeding without, too low to see something on ultrasound, with a low progesterone level, if you give supplementation of progesterone, you will support the pregnancy that otherwise would have miscarried, okay? And of course, the gold standard of diagnosis in early trimester vaginal bleeding is a ultrasound, as John Stewart is illustrating here. So the differential in early first trimester vaginal bleeding covers the gamut of organs, all over that area. So you can see ectopic pregnancies, cervical abnormalities, you can see missed or spontaneous abortions, obviously, a subchorionic hemorrhage if you do have a placental implantation, and then obviously the idiopathic bleeding of normal pregnancy. Realize that up to 25% of all conceived pregnancies will miscarry, and that by the time the patient gets to you, they've kind of cleared a first hurdle, actually, of bleeding in pregnancy. And ultimately, what's our outcome, right? So you see the patient, you do the blood test, they come back, their beta is 3,000, you have an early yolk sac or an early gestational sac potentially, and then you say, all right, follow up with the doctor, it was nice knowing you. Give them ROGAM if they're Rh negative, and you're done, right? It's easy, so much so that we don't really think. But at the end of the day, the patient that's coming to you may have a lot of questions. And so the focus of this actually is how do you answer the questions the patient has that you're probably not thinking about. And a lot of it is not complicated medically, but it can be complicated psychosocially. So the first question is, the patient wants to know they are bleeding. What are the actual chances they're going to have a miscarriage? So you can see that at 13 weeks, the kind of bleeding averages out to not correlate with the likelihood of miscarriage. But before 13 weeks, the kind of bleeding, quantification, is it spotting, is it heavy, will directly correlate with the likelihood of miscarriage. And like I said, 25% of all conceived pregnancies may miscarry, but by the time they come to you, it's actually closer to 10%, okay? If they're spotting, their likelihood of miscarriage is actually only 4%. And these are reassuring numbers that your patient would want to know once they come to the ER, because like I said, these patients are very scary. So you sent them for sono, and they have a heartbeat. Well, now they're like, I not only was bleeding, but I have a heartbeat, I'm gonna be okay, right? So in a study done of consecutive diagnosed pregnancies with a fetal heartbeat, so this was a Canadian study where they could grab all the patients that came through, they found that of 668 patients who were diagnosed, who were seen early trimester and had a sonogram with a heartbeat, 618 went to live births, which was a 7.5% miscarriage rate. And when they look back at the sonogram findings and the bleeding findings, they realized that if you have a low heart rate at an early first trimester sonogram, anything less than 116 beats per minute, or a small gestational sac or crown rump length on the sonogram, lower than the expected size for dates, plus minus vaginal bleeding of any kind, you had a significantly higher likelihood of miscarriage. So what that means for your patient is if they do have a heartbeat and they're bleeding, but you know they have a low heart rate or a small gestational sac, make sure you are much clearer that they need to follow up as soon as possible, okay? Don't set up that they're likely to miscarriage, but you should know in your head that they may have a more likely chance and that follow-up is much more important for them. So your patient wants to know long-term, does vaginal bleeding correlate with any long-term consequences throughout the pregnancy? And it's actually shown that it does. So in a meta-analysis done of all studies on vaginal bleeding and pregnancy from 1979 to 2009, they found that there are maternal outcomes that are seen with vaginal bleeding and pregnancy. So patients who bleed in the first trimester are more likely to have premature rupture of membranes and antepartum hemorrhage. Antepartum hemorrhage was related either to placenta previa or placenta accreta, okay? The perinatal outcomes, and this can be critically important, again, for the follow-up of the patient. They found that these patients did have a higher likelihood of preterm delivery, IUGR, or small for gestational age, low birth weight, and other causes of perinatal morbidity and mortality. And again, this just goes to the counseling you're going to give the patient. When they come in and they're bleeding, it's very early in the pregnancy, you do see a heartbeat. Okay, so these are patients that are going to go on to continue to be pregnant. Make sure they understand that follow-up is critical and that they should continue to have healthy habits during their pregnancy. Okay? So again, what can your patient do to prevent a miscarriage? Not a lot, right? We all know that patients who bleed in the first trimester of pregnancy may or may not go on to miscarriage due to many things that they can't control. They cannot control their age. They cannot control how multiparous they are at that point. I guess in the future they can. But there are avoidable risk factors to having miscarriage: smoking, drinking alcohol, and pelvic trauma. So you want to continue to advise them not to smoke, even if they had smoked up to that point, not to drink, and to refrain from any pelvic trauma, whatever that may be, until their pregnancy is further along. So please, I'm sure that I'm under 5 minutes, but that's not surprising. If you remember just one thing about this, again, this is not the complicated medical interaction of serotonin syndrome and all the molecules that Danny was talking about. This is about the psychosocial interaction you're going to have with your patient. These patients are vulnerable, okay? They're scared and they don't know a lot. You do. This is not exciting for you, but it is terrifying for them. So just sit with them for a couple of minutes, ask the questions, know that you can reassure them that they are greater than 90% likely, if they're only having spotting and they have a heartbeat, okay, to have a full-term healthy pregnancy, and that probably will be the best thing you can tell them at the time. Okay, thank you.